Hello everyone, welcome back to another masterclass. I'm Dr. Naveed Ul Zafar, clinical physiotherapist. Now, most of us are MSK physios. We think joints, muscles, and nerves. But here is what I've learned. Sometimes a patient walks into your clinic with what looks like a shoulder problem, but it's not. And if you treat it like one, you can do serious harm. Today, two cases that will test whether you see the whole patient or just the painful part. Case 1. A man with shoulder and arm pain looks mechanical, but the details don't add up. Case 2. A man with back pain is older. There is a certain quality to it, something you have never seen before. Miss it, and the outcome could be fatal. You know the format. I'll show you the case. You pause, you think, then we will go through it. No spoon feeding. Let's begin. Case 1. A 58-year-old man comes in with left shoulder and upper arm pain. He says it started 2 days ago while he was climbing stairs. The pain is dull, like pressure, and it goes into his jaw. He also felt a bit breathless and nauseous at the time. He's a smoker, has high blood pressure. Now here's the confusing part. You check his shoulder, range is full, no painful arc, no weakness. Special tests are negative. Cervical spine screening is also negative. So what's the most appropriate next step? Option A. Start rotator cuff strengthening and scapular stabilization. Option B. Refer for cervical spine MRI to rule out disc pathology. Option C. Stop the assessment and refer immediately for cardiac evaluation. Option D. Diagnose adhesive capsulitis and begin stretching. Pause here. Look at every detail. The onset, the quality, the associated symptoms, the negative tests. What are you going to do? Press play when you're ready. If you picked C, cardiac referral, you are right, but I made the options tricky for a reason. Let's go through them one by one. Start strengthening and scapular work. This is what we default to as physios. Shoulder pain equals shoulder rehab. But let me ask you, what exactly are you treating? There is no weakness, no painful arc, special tests are negative, range is full, there is no musculoskeletal impairment. So why are you prescribing exercises? Because the patient said shoulder pain? You need to ask yourself, does this clinical picture match any shoulder pathology I know? If it doesn't, stop. Think, look elsewhere. Refer for cervical MRI. The pain is in the shoulder and arm. Could it be the neck? Possibly. Cervical radiculopathy can refer to the shoulder, but look at the details. The pain is dull and pressure-like, not sharp or shooting. It goes to the jaw, not a dermatomal pattern. It came on with exertion, not neck movement, and cervical screening was negative. If you're ordering an MRI for every shoulder pain that doesn't fit, you are going to scan a lot of necks, but more importantly, you are going to miss the heart. Adhesive capsulitis, this one is tempting only if you are not paying attention. Frozen shoulder gives you stiffness, especially loss of passive external rotation. This man has full range, no capsular pattern, no night pain, no gradual onset. His pain started 2 days ago on stairs. This is not frozen shoulder. Don't throw a diagnosis at a patient just because you want to name something. Cardiac referral, here's what's happening. The heart muscle isn't getting enough oxygen. We call this ischemia. The heart shares its nerve supply with the shoulder, arm, neck, and jaw. So when the heart is in trouble, the brain misinterprets where the pain is coming from. This is called referred pain, and that is why a heart attack can present as shoulder pain. What clues tell you this isn't a shoulder problem? The pain is dull, pressure-like, not mechanical. It started with exertion, stairs, not movement. It radiates to the jaw. No shoulder pathology does that. There are associated symptoms, breathlessness, nausea. The patient has risk factors, smoking, hypertension, and your entire shoulder exam is negative. All of it. When the whole exam is negative, but the patient is in pain, think beyond the joint. What do? You stop the physio assessment, you sit the patient down, you ask directly, do you have any chest tightness right now? You check vitals if you can, and you call for emergency help. Don't send him home. Don't book a follow-up. This could be unstable angina or a heart attack in progress. So, your takeaways: number 1. A completely normal shoulder exam with exertional jaw pain is cardiac until proven otherwise. Number 2. Risk factors matter. Always take a medical history. Number 3. If the pain doesn't match any pattern, don't force it. Number 4. Referring for the right reason is not failure, it's clinical wisdom. Alright, that was case 1, catching what does not belong in your clinic. Now case 2. This one is about a back pain that comes with warning most physios have never been taught to look for. Alright, case number 2. A 70-year-old man comes to your clinic with low back pain. He says it started yesterday. Suddenly, while he was sitting at home, not lifting anything, not bending, just sitting. The pain is deep, constant, and boring, like something is gnawing inside. It doesn't change with movement or rest. He also feels it slightly in his abdomen. He has a history of hypertension and he is a past smoker. On examination, he is uncomfortable, but his lumbar spine range is full, no neurological deficits. Vital signs show his blood pressure is lower than normal and his heart rate is a bit elevated. What is the most appropriate next step? Option A, diagnose mechanical low back pain and start core exercises. Option B, refer for urgent vascular assessment. Suspected abdominal aortic aneurysm. Option C, refer for lumbar spine x-ray and routine physiotherapy. Option D, prescribe NSAIDs, heat therapy, and review in 1 week. Pause. This is not a typical back pain. Read it again. What's different about it? Press play when you're ready. The correct answer is B, vascular assessment for suspected abdominal aortic aneurysm. If you have never heard of this, presenting as back pain, you are not alone. Let's go through it. Mechanical back pain and core exercises. This is our default, but let's look at the facts. Mechanical pain changes with movement. It gets better or worse depending on what you do. This man's pain is constant, doesn't change, started while sitting, no injury, no loading. You can't just call it non-specific low back pain and give exercises. You have to ask, why is this pain constant and non-mechanical? Lumbar x-ray and routine physio. An x-ray shows bones, it won't show an aneurysm. And a routine physio referral means you're handing this patient off without actually thinking about what's going on. The physio down the line might also miss it. You need to act, not delegate. NSAIDs and review in a week. This is dangerous. NSAIDs can actually make an aneurysm worse if it's leaking because they affect platelet function. And waiting a week, if this is a leaking or expanding aneurysm, he could rupture in that time, and a ruptured abdominal aortic aneurysm has a mortality rate of over 80%. You cannot wait. Abdominal aortic aneurysm. So what is this? The aorta is the biggest artery in your body. It runs from your heart down through your abdomen. In some people, older, smokers, hypertensives, the wall of the aorta can weaken and balloon out. That is an aneurysm. It can expand slowly or leak, and when it does, it causes deep, boring pain in the back and abdomen. The pain is constant, not mechanical. It doesn't change with position. The warning signs. Number 1, older patient, usually over 65. Number 2, smoker or past smoker. Number 3, hypertensive. Number 4, sudden onset of constant, boring back pain that doesn't change with movement. Number 5, sometimes they feel it in the abdomen too. Number 6, low blood pressure and elevated heart rate can indicate a leak. These are not MSK signs, these are vascular signs. What do? You stop your assessment, you don't palpate deeply over the abdomen, you can make things worse. You check their vitals, you ask about any abdominal pain or dizziness, and you refer immediately to the emergency department. Tell them suspected abdominal aortic aneurysm, sudden onset, constant back pain, older patient, history of hypertension and smoking. This is a surgical emergency. So, your takeaways: number 1, constant, non mechanical back pain, especially in an older patient, is a red flag. Number 2, know the risk factors for abdominal aortic aneurysm: age, smoking, hypertension, male. Number 3, back pain with abdominal symptoms is never just back pain. Number 4, don't delay. A leaking aneurysm is a time bomb. Alright, 2 cardiovascular cases, one where the heart tricked the shoulder, one where a blood vessel tricked the back. Both reminded us of the same thing. We treat the whole patient, not just the painful part. If this was useful, drop a comment below. Ever seen something that looked MSK but wasn't? I'd love to hear. Subscribe if you haven't. Share this with your colleagues. It might save someone's life one day. I'm Dr. Naveed Ul Zafar. See you in the next one.